on the World Tobacco Cessation Day. Join us for a session which is targeted toward understanding what the nicotine use disorder or the tobacco addiction looks like, understanding the basics, and how a person, like what everyone, as the data suggests, that roughly 75% of the smokers do want to quit, and how we can able to help using a comprehensive care model, which include the pharmacotherapy, psychotherapy, and of course, the use of non-invasive brain stimulation methods. To understand more in depth about the tobacco addiction and the basic phenology terms, I would like to invite Dr. Shyam Sundar, who is a consultant psychiatrist in Buddhi Clinic, having done his fellowship in NIMHANS in addiction medicine. He is the right person to enlighten us on the topic. Over to you, Dr. Shyam. So I think by the time Dr. Sham puts the slide, I will just get his intro. So Dr. Sham is a consultant psychiatrist with MD Psychiatry and postdoctoral fellowship in addiction medicine from NIMHANS, Bangalore. He have a rich experience in managing clients with various addictions. He was recipient of Sharda Menon Gold Medal in the year 2022 for excellence in National DNB Psychiatry examination. He is passionate to help his clients quit addictive behaviors and achieve recovery, finding meaning and purpose.
Good morning, everyone. So today we'll try to discuss about various aspects of nicotine use disorders. So starting from neurobiology, I'll take you through how to assess nicotine dependence clinically, and then maybe we can go about and discuss about psychotherapy and pharmacotherapy. So to start with, uh, we'll start with the neurobiology. So coming to the epidemiology of tobacco use disorder, Um the tobacco consumption over the past decades have been increasing globally. The Global Adult Tobacco Survey um, has revealed that 10.7% of adults are smoking and 21.4% use smokeless tobacco. So overall, tobacco consumption comes roughly around 28.6. Many of the people who tobacco also use most of tobacco. So the overall roughly around 20. And even more recent suggests that the economic data that tobacco use disorder, which includes harmful use pattern as well as dependence, etc. So accounts for roughly around 20% prevalence, and treatment gap for these disorders is close to 92%. There are various forms of tobacco. The smoking forms of tobacco, as in the picture, it includes various forms like cigarettes, BDs, cigars, hookah, pipe, etc. So on the right hand side, I have shown the new electronic nicotine devices. These are called vapes in common lingo. So these are also becoming very, very prevalent among the young population, especially those who are in college and young adults. So they use these vapes. Although these vapes are prohibited legally in many states of India, they are still easily available to them through online platforms, etc. How smoking form differs from the smokeless form is that the nicotine immediately peaks in the blood. So it reaches the brain approximately 20 seconds after they inhale. It goes to the alveoli, and from there, through alveolar capillaries, the nicotine reaches the bloodstream and it reaches the brain. And it occupies the nicotinic acetylcholine receptors located in many parts of the brain. So through the nicotinic acetylcholine receptors only, it produces the pleasurable feeling or the rewarding sensation. So within a single puff of cigarette, it can reach around um, one third of the nicotinic acetylcholine receptors, wherein um, it reaches around 88% after smoking one complete cigarette. So this is a very huge percentage, and Nicotine is also used in the form of vapes. So the vapes account for the newer nicotine delivery system. So the vapes also deliver erratic way of smoke nicotine directly to the blood. So say smoker, unlike alcohol, for which each time you drink a specific quantity of alcohol, the blood concentration is similar. But in with respect to smoking, with respect to the um, even how much cigarette do you smoke, so all these results in differences in the quantity of nicotine reaching. So smokeless forms of tobacco, I have mentioned many such types. The common ones used are gutka, pan masala, snuff, and snus, etc. Tobacco powder also, sniffing powder kind of tobacco also is being used in many parts of the world. So compared to the smoking forms of tobacco, smokeless forms generally increase the nicotine levels gradually, wherein in smoking it reaches a peak as soon as the person takes few puffs of smoke. So smokeless tobacco people use for a longer time, and it also maintains the level for almost 2 hours. So when we see about nicotine replacement therapy, we will see how a similar mechanism is used in nicotine gums, nicotine lozenges, etc. Next slide, please. But whatever be the form of tobacco, the basic chemical remains the same, that is nicotine. And along with nicotine, many other chemicals are added to these products to make them more addictive. So nicotine, as we all know, is C10H14N2. That is the chemical form of it. It is a psychostimulant and mood modulator. So we all know different. There are different kinds of drugs. Some are stimulating, some are depressing, right? For example, opioids, benzodiazepines, alcohol. All these are um, depressing drugs, whereas cocaine, amphetamines, etc., are stimulants. But when we take nicotine, for example, it is neither a stimulant, neither a pure stimulant nor a pure relaxant. It is a combination of both. So in subsequent slides, we'll see why we say this. So it's a psychostimulant and a mood modulator. That is how we can place this among other substances. It can temporarily improve the alertness and relieve the withdrawal. The addiction occurs due to the arousal, the relaxation, and the relief from stress. So all these aspects contribute to the addiction, and it can also be called as a mood leveler because it the effect of nicotine on your body will depend on the state that you are in while using it. For example, if you are using it during time of fatigue, it can cause arousal, and if you're using it during times of anxiety, it can cause relaxation. So it can act as both basically. And many a times over chronic use of nicotine, people develop significant withdrawal symptoms, and many relief from anxiety that people say could actually be the withdrawal symptom getting better after nicotine use. And the half life of nicotine is 2 hours. Next slide, please. So going deep into the neurobiology, so this picture symbolizes the main pathway of all major addictions. So the pathway starts from the ventral tegmental area, which is represented by the orange circle. So any substance, especially nicotine, when it is taken, it goes and acts on the acetylcholine receptors in the ventral tegmental area. So this is an area in the midbrain. From there, projections go to nucleus accumbens, and from there it goes to the prefrontal cortex. This is called the mesocortical dopamine pathway. This pathway is essential for reward, and this pathway is generally activated by normal rewards like food, water, sex, positive social interactions, and other common rewards. But the moment nicotine enters the system, this pathway is hijacked by nicotine. So this is an interesting way of conceptualizing nicotine addiction. So this is called the three-stage cycle of addiction by Coops. So this involves the first is binge intoxication stage, which is at the top. So as soon as you take the nicotine through any form, it can produce an intoxication-like state. This state is handled by basal ganglia, and the process involved in this cycle, this stage is called incentive salience. So gradually, as a person continues to take nicotine regularly, this incentive salience develops for nicotine, which means that out of all the other activities, nicotine use is given more and more salience, more importance is given to the nicotine use. So once the intoxication stage settles down, like we saw, the half life is just 2 hours for nicotine. So once that fades away, they move to the next stage, which is called negative affect or withdrawal state. So during this state, the extended amygdala goes is activated. So amygdala, as we all know, is a seat for processing negative emotions. So when this gets activated, it activates the withdrawal state. So withdrawal is not just a physical state; it is also an emotional state. So in this state, the process that is involved is reward deficit and stress surfeit. So reward deficit is something similar to anhedonia. Nothing is feeling pleasurable to you anymore, and also you develop even uh, small stress can induce a high degree of negative emotions inside you. That is called stress surfeit. So once external amygdala gets activated, this stage starts, and it leads on to something called preoccupation anticipation stage. So at this stage only, the craving is at its peak. The person starts thinking about when they can have the next cigarette. So they are not able to inhibit this craving, and this is mediated by prefrontal cortex, so which generally exerts the cognitive control. So once that control gets deranged, the stage will again go for binge intoxication, wherein the person will again go and consume tobacco. So like this, their brain pathways undergo repeated cycles of binge intoxication, withdrawal, and preoccupation. So this keeps happening, and the person gets caught in the loop of addiction. So these are the major brain areas that we need to know that are highlighted in yellow: basal ganglia, extended amygdala, and prefrontal cortex. This is what maintains the addiction. So now coming to the main culprit, that is the nicotinic acetylcholine receptors. So there are various types of receptors, and out of these, the alpha 4 beta 2 receptors are the ones that play a major role in nicotine addiction. So these are expressed throughout the brain, including the mesolimbic dopamine system. So this receptor is dynamically managed by the homeostasis. So, but when people are exposed to smoke, exposed to even smokeless tobacco, so the nicotine um, binding, it changes. The receptor can change in its sensitivity, it can change in its number, like up regulation or down regulation, depending on the amount of nicotine levels, or it can go in for some structural changes also. And these are mediated by genetic mechanisms. Okay, so this receptor forms the core of nicotine addiction. So that is why partial agonists like varenicline, they attenuate the voluntary nicotine taking behavior by promoting the long-term smoking abstinence. So through acting directly on the receptors, it can produce a lot of benefits like managing the craving, managing the withdrawal symptoms, etc. Yeah. So this is another important slide. So this slide says that the the black neuron, that is a dopamine neuron. So that is basically the place where um, nicotine acts, and it activates the receptor. So once nicotine activates these neurons, dopamine gets released in the ventral tegmental area, and from here As we see, it has links to various other neurons like GABAergic neurons, cholinergic neurons, glutamatergic neurons, etc. So, due to these interplay of various neurotransmitter systems, tobacco causes mixed effects. It can cause a pleasurable effect, it can cause a relaxing effect by activating GABA, it can produce a stimulatory effect, it can also, you know, cause changes to the memory related circuits through cholinergic neurotransmission. So, multiple neurotransmitters are involved, and that is why the effect is also very differential. And this is one of the major reasons why. This is one of the major reasons why nicotine addiction is a very complex addiction because it acts on multiple neurotransmitter systems like dopamine, serotonin, norepinephrine, GABA, and glutamate. And finally, the reward pathway goes for a structural changes, which is called neuroadaptation. So, neuroadaptation means the receptors are going for a structural and functional change, which needs a lot of effort to get back to the previous homeostasis state. Yeah, so this says a brief about the nicotine addiction cycle. So, initially, a person smokes, and the levels of nicotine peak in the bloodstream. So, it causes all the different effects like arousal, mood modulation, pleasure, etc. And over the time, they develop tolerance and physical dependence. Uh, Drug abstinence uh, produces withdrawal symptoms over time, and later the craving happens, and the person continues to get stuck in the loop of nicotine addiction. Is it just the nicotine receptors? Are there any other changes? Because many people who smoke, who try smoking, there are many people who don't develop the addiction, right? So what changes you know make a person vulnerable to smoking addiction or tobacco addiction? So these are various different genetic mechanisms that have been found in people with tobacco addiction. So these include the genes controlling metabolic activity like CYP2A6, or nicotinic acetylcholine receptor activity like various points have been mentioned like ChRNA4, various acetylcholine receptor related genes, dopaminergic related genes like DRD2, DRD3, and 4, even SLC6A2, 6A4, etc., and serotonergic activity related genes like HTR2A, and opioidergic activity, OPRM1. So these are various different genes that are involved in uh, nicotine addiction. So this says about the nicotine levels, and this is a very important slide of this presentation. So what we need to know is that this graph that is there in blue. So you can say as soon as a person starts smoking the first cigarette in the morning, they have multiple peaks. So each peak that is depicted here is to one cigarette. Okay. So as we see, as a person smokes multiple cigarettes throughout the day, so with each peak, the level goes up and up and up until the afternoon or evening time, something somewhere like that. And then they once they continue to smoke, it reaches the peak. So at the night, let's say maybe roughly around 10 o'clock, 10 p.m. or somewhere, the person takes their last cigarette. So that after that, the nicotine levels they fall significantly. Okay. So once the this happens, what happens is that in the brain acetylcholine receptors, they go for something called resensitization. So throughout the day, up till the last cigarette, they get um, activated, they get depolarized, and overnight the abstinence is going to lead on to resensitization of the receptors. So what this means is that as soon as the nicotine effect will wear off in the morning, the person is going to have extreme craving, and this extreme craving is related to smoking as soon as they get up from the sleep. So higher the level of dependence, sooner they will need the first cigarette. So what happens in this overnight abstinence is that the acetylcholine receptor subtypes begin to change in their morphology, and even molecular mechanisms of neuroadaptations come into play. So a person's cigarette smokes from the morning till night, it is going to maintain a certain level of nicotine in the bloodstream, and when it suddenly gets cut off overnight during the overnight abstinence, the receptors are going to go for resensitization and they go for morphological changes, which make the person crave more for the cigarette in the early. So far, whatever we have seen are that nicotine activates the reward pathway and nicotine hijacks the reward pathway. Nicotinic receptors undergo changes during the overnight abstinence, and also there are various three-stage cycle that is there. So these are all we have seen. So these all happen within the person's brain. So what happens externally? So what is the role of external factors? So nicotine is one substance for which something called conditioning plays a major role. So we all know about Ivan Pavlov's experiment, right? So wherein he used to feed the dog and ring the bell, and over time, just ringing the bell is enough to produce a salivation response. So similarly, people with tobacco use, they develop conditioning to various neutral stimuli. These are called conditioned cues. So these are nothing but drug associated memories that become established during the fine tuned dosing of nicotine. For example, it is not just the cigarettes that activate the person's reward system. Over the time, it could just be thinking about cigarettes, or seeing a cigarette ad or something, or seeing someone else smoking, or just crossing the shop where they used to buy cigarettes. So all these are stimulating the person in the same way. So these are called drug related cues. So memory is also a significant component of nicotine addiction. So it is said that over a few months of smoking, a smoker might have more than 1,000 different cues that may activate his smoking behavior, and these may be directly related to the cigarettes, or these may be unrelated also. For example, many times we see people smoking when they are feeling stress in the workplace, or most often we see people who are smoking when the friend is smoking, they also feel like smoking. Sometimes it is the cold exposure, or if it is raining, people feel like smoking. So like this, people associate a lot of actions, normal situations to smoking, and it becomes a conditioned response. Okay, so that is the role of conditioning. And in this, I also put a picture, which is an advertisement for cigarettes. So often, young people who are seemingly appearing very happy are used in advertisements, and this also creates a conditioning in people's minds. The same thing has to do with cinema. So many a times, people, the heroes, or the most powerful person is shown uh, using a cigarette. So that creates conditioning in their minds that cigarette is associated with more power or more control, something like that. So conditioning could include everyday events like driving a car, finishing a meal, talking on the phone, waking up from sleep, or just taking a break from work. So all these could be associated with tobacco use. And tobacco users also link their mood state, internal mood states, with need for using tobacco. So all these things we should keep in mind while dealing with the patient with tobacco addiction. Next slide, please. So this is what we discussed in the previous slide. So the acetylcholine receptors throughout the day they undergo various changes. Initially, they are activated through cigarette smoking, and once it falls, they go for desensitization, and over the time, they also go for further worsening of the desensitization, leading to changes in the number, sensitivity, etc. And finally, they result in withdrawal syndrome. So this forms the core of nicotine addiction. Next slide. So this is another mechanism by which nicotine causes addiction, but this is not a major mechanism; it's a minor mechanism. This is the monoamino oxidase. So, not nicotine, but other products like acetaldehyde related products with biogenic amines, like all these things, benzoquinones, naphthylamine, etc. So these products are formed during smoking. So these products can inhibit the MAO and MAOB, so which can also increase the monoamines in the synaptic uh, in the synapse, and it can also produce a pleasurable feeling. So MAO inhibition by these products of smoking is also one mechanism of um, smoking being a addictive behavior. Next slide. Yeah, this we have already discussed. Next slide. Yeah, this is environmental factors. What other factors have been studied in various large scale studies is that poor parental support, low socioeconomic status, peer group influence, drug availability. So, if the drug is easily available everywhere, the chances of people getting addicted to it, are high. And also social isolation and loneliness. So, all these are different environmental factors that have been directly linked to the dependence risk of tobacco. Next slide. And again, this we already discussed to some extent, like the pre-drug subjective state. If you take the drug during fatigue, tobacco is going to activate you. If you're taking it during times of arousal like anxiety or anger, etc., it is going to cause you the relaxation. So this effect also is quite addictive, because they can rely on smoke to modify their mood state according to their pre-drug subjective mood states. And also mental illness like depression, anxiety, etc. So people are more prone for using tobacco. So this is called self-medication hypothesis. These are the host factors associated with dependence. Next slide. So to summarize everything, addiction is a chronic brain disease. So tobacco addiction is not just a habit; it is a disease. And nicotine has complex mechanism of action. We discussed how nicotine is activating the neurons in ventral tegmental area, which further activate various neurotransmitter systems like GABA, glutamate, serotonin, norepinephrine, and dopamine. So this is what makes it very difficult to quit. And both smoking and smokeless tobacco have equally addictive potential and are equally harmful. Although smoking is going to produce acute peaks, wherein smokeless is going to produce a gradual increase in nicotine levels. And neuroadaptation is the process that signals the onset of addiction. So receptor dynamics, genetic factors, enzyme inhibition all play a supportive role. And environmental and other host factors, they add on to the neurobiological factors to produce tobacco addiction. So this summarizes the gist of neurobiology of tobacco addiction. Next slide. So from here we have to move on to how we can apply this clinically. So when a patient comes to us, we can give them some assessments to score them. Next slide. The commonly used test is the Fagerstrom's test of nicotine dependence. This is for smoking. So the questions are: how soon after waking you smoke your first cigarette? So this is what we discussed during the resensitization. So within 5 minutes, 5 to 30 minutes, 31 to 60 minutes. Next question is, do you find it difficult to refrain from smoking in places where it is prohibited, like church, library, etc., where it is generally prohibited to smoke, but still you are not able to control your urge? So yes or no. Which cigarette would you hate to give up? The first cigarette in the morning or any other cigarette? And how many cigarettes do you smoke in a day? 10 or less, 11 to 20, 21 to 30, 31 or more. Next is, do you smoke more frequently in the morning? Yes or no? Do you smoke even if you are sick in the bed most of the time in the day? Yes or no? So this summarizes the various aspects of dependence, and any score 8 and above suggests high dependence, 5 to 7 is moderate, 3 to 4 is low, 1 to 2 is low. 3 to 4 is low to moderate, 1 to 2 is low. So based on this, you can do an assessment and you can categorize them into which category they belong to. Next slide. Yeah, next. So if you are previous slide, yeah, keep it like this. So if you are too busy, you are not able to apply the entire scale. You can use only the first question and the fourth question. That is called heaviness of smoking index. The total score is 6. You can rate out of 6 how much they score. So if you have a busy OPD, you can administer the entire scale. Just use these two questions. Next, this is for smokeless tobacco. So this is almost similar. There are a few questions that are different. For example, um, second point: how often do you intentionally swallow the tobacco juice? Is it always, sometimes, or is it never? And remaining are almost the similar. So here 5 and more is severe dependence, 4 or less is low to moderate. Next. So this is another objective measure that you can use in your clinic. This is called the carbon monoxide breath test. So this device costs around somewhere between 40,000 bucks to 1 lakh. So this will give a idea about in the exhaled air how much is the nicotine levels. Sorry, how much is the carbon monoxide levels, which directly contribute, which directly correlate with the number of cigarettes that a person is smoking. So if it is 15 to 30 ppm of carbon monoxide, it is moderate to heavy smoking. If it is 7 to 14, it is slight. Next page. Yeah. So that is about the assessments. Next. Next. Yeah. So this is ICD 11 criteria. We have various different categories in ICD 11, which is no substance use. Studies from the bottom of the pyramid. No substance use, low risk use, hazardous use, single episode of harmful use, harmful pattern of substance use, and substance dependence. So the hazardous use means that the person is using the substance, but no harm has happened. But there is a high risk that a harm would happen. Single episode of harmful substance uses, yeah, as the name suggests, some harm has already happened, but only once. If multiple harms have happened, then that is called harmful pattern itself. And finally, dependence means there are three criteria, which we'll see in the next slide, to satisfy diagnosis of dependence. Next slide. So these three are the ICD-11 criteria. One is impaired control, which means that difficulty to control the onset, quantity, and termination of nicotine use, and associated with a strong internal drive to use nicotine. So this is the first point. Second point is increasing priority. So the person neglects all the other parts of their life despite the negative consequences. That is called increasing priority given to substance use. And finally, physiological features, which means that tolerance and withdrawal symptoms. So tolerance means the need to increase the quantity over a period of time to achieve the desirable effect. And withdrawal means physiological symptoms that are unique to a substance that develop during times of reduction of the substance or times of abstinence from the substance. So often people continue to use tobacco to alleviate the withdrawal effects. So that is point number three. So out of this three, if two or more is present over a period of 12 months, but if it is quite high, this 12 months period is not even required. Even 3 months is enough if it is very severe. So this is about the ICD-11 criteria. Next slide. So nicotine withdrawal, these are the various clinical features. So dysphoric or depressive mood, insomnia, irritability, anger, anxiety, difficulty in concentrating, restlessness, bradycardia, increased appetite, and craving for tobacco. So these are the withdrawal features of nicotine. Other physical symptoms may include increased cough and mouth ulceration. Next slide. So this is the DSM-5 TR criteria. So this has many sub criteria like impaired control, social impairment, risky use, and pharmacological criteria like tolerance and withdrawal. So this is somewhat similar to ICD-11 only, but this is slightly more extensive. Next slide. So DSM-5 TR also gives following points as withdrawal symptoms: irritability, frustration, anger, anxiety, difficulty concentrating, increased appetite, restlessness, depressed mood, and insomnia. So if patient has four or more of these features, you can in the past 24 hours, you can diagnose them as nicotine withdrawal syndrome. Next. So now we have assessed the persons using FTND. We have also diagnosed based on ICD-11 or DSM-5 TR what is the criteria this person is fitting into, and now we have to manage. So next slide. So before we start our treatment, we have to fix what outcomes we are measuring. So often the family members who bring the patient to us, they'll expect complete abstinence. They'll say, doctor, my husband or my uh, family member should not use tobacco at all. You do something and make that happen. But generally, for any addiction, including tobacco addiction, it doesn't happen overnight. The recovery does not happen overnight. So we have to set some realistic expectations. So what we have to tell the patients and the caregiver is that my initial priority is to reduce the withdrawal symptoms, then to attenuate the reinforcing effects of nicotine, which is to manage the craving, and to decrease the quantity of use. So if the person is able to reduce the cigarette use from 20 cigarettes per day to 5 cigarettes per day, that is also a definition of recovery. And from 5 later, we can go on to complete abstinence. So we have to give a realistic perspective to the patients. This is the first step in treatment. Next. So nicotine replacement therapy, there are various things that are FDA approved. So these forms are gums, patches, nasal spray, next, and nicotine vapor inhaler and lozenges. So all these forms of nicotine replacement are approved by FDA. Next slide. Yeah. So why NRT is very important in recovery from tobacco addiction is that it gives a controlled dose of nicotine. So without exposure to many harmful chemicals, it just introduces nicotine in a purest form and in a dose that we can be aware of. So it is, for example, if it is a gum, it is available as 2 mg, 4 mg gums. If it is a patch, it's available as 7 mg, 14 mg. 28 mg patch, etc. So, um, the major reason why nicotine replacement therapy is beneficial is that it can provide nicotine without exposing the person to harmful chemicals. It can mimic, the normal fluctuations in their nicotine levels. It can address that. So the person does not have craving as well as the withdrawal symptoms. It has dual advantages. uh, and it has 50 to 70% quit rates. So even if the person is not very keen on quitting the smoking or quitting the tobacco use, if you start nicotine replacement therapy, anyways, 50 to 70% of the individuals are going to quit. And another advantage is that it can be combined. For example, the same person you can give patch as well as the nicotine gum, or patch as well as the lozenge. So that is another advantage. Next, yeah, these are the various methods. Next, yeah. So many clinicians might ask, this also has nicotine, then why are you giving it? Aren't you giving the same substance that the person is addicted to? So it is partly true that we are giving something that is, that is the root cause of addiction, but we are not giving it in a very haphazard way. Like, for example, if a person is smoking, the levels of nicotine go haywire in the brain, which is what is causing the addictive behavior. Wherein here we are giving purified nicotine in very low dose and very slower doses. And other chemicals like carbon monoxide, tar, benzene, polonium. So these are some other chemicals that are related to cancer and other health risk. So we are not giving all these other chemicals. So it is quite safe, and it can manage both withdrawal and craving. So long-term use also is found to be safe without any major side effects. So this is what we have to clarify. Next, and how do we prescribe it? So if it is a gums, we can give 2 mg or 4 mg every 2 hours. So if the person is smoking less than 20 cigarettes, use 2 mg gums. If more than 20 cigarettes, use 4 mg gums. And the gums have to be used in a method called chew and park method, which means that people have to chew the gum for around 2 to 5 minutes. Then they have to park it in the gingival fossa, which is the space between the inner aspect of the lip and the gums. They have to keep it there for around 10 to 15 minutes. So 5 minutes of chewing, 10 to 15 minutes of um, parking in the gingival fossa. So this will create um, nicotine level. So the nicotine will get absorbed transmucosally, and it will stabilize the craving as well as the withdrawal symptoms for nicotine. So that's about the gums. In terms of lozenges, instead of chewing and parking, they have to just keep it under the tongue, or they need to just roll it in their mouth. So that nicotine also gets absorbed transmucosally, and it can stabilize the nicotine levels in the brain to aid in the recovery. So often it is advisable not to swallow the nicotine juice that is mixed with saliva, because it can cause acute gastritis. Next slide. This is about the patches. Patches are also very useful and very, what to say, very effective forms of NRT compared to gums and lozenges, because it is just like you can stick and you can forget about it. Whereas in terms of lozenges or gums, we have to keep taking it every 2 hours for it to be effective. So prescribing patches will depend on, again, if the person is using more than 20 cigarettes, you start with 21 mg. If the person is using uh, less than 20 cigarettes, you start with 14 mg patches. So this is generally well tolerated. And while you can, if the person is has reduced the smoking, then for every 2 to 4 weeks, you can reduce the dose by 7 mg. So you'll start with 21 mg. For example, the person is has reduced the smoking or has quit the smoking, then after 2 weeks you make it 14. After another 2 weeks you make it 7, and after another 2 weeks you stop it. So based on the individual response and based on the outcomes, you can modify this interval of tapering. Next, these are some other upcoming forms of nicotine replacement therapy. These include buccal strips or buccal films, which is shown in the picture, which you can just keep it in the buccal area, and sprays are also available. Nasal spray, which is called this Nicofresh, is available in India. Other forms of inhalational forms are there. These are not very widely available in our country. And previously, there used to be this electric nicotine delivery systems, which is nothing but the e-cigarettes. That was initially many years back. It was thought to be an alternative to smoking, but right now we have what we know is that they could be even more harmful than cigarettes due to various chemicals mixed in the form of flavors, etc. So this electronic nicotine delivery system is banned in India. So we are left with the common options like gums, lozenges, patches, buccal strips and films, and sprays. Next, what could be the side effects? The chewing gum can sometimes cause something called jaw fatigue from repeated chewing. It can also cause gastritis if they swallow the nicotine juice. It can cause nausea, insomnia, etc. That is why we have to dose it before 6 p.m. They have to complete the dosages. And in a day, people can take roughly between 5 to 7 or 8 dosages every 2 hours. And it can also cause headache sometimes. And the patch that we use can sometimes cause skin irritation. That is the reason why you need to keep changing the site of the patches. It has to be applied on any non-hairy areas of the body like shoulders, upper back, upper chest, etc. Next. So if we are starting NRT and the person is not able to completely quit the tobacco use, sometimes we can add on some medications. These are varenicline, bupropion, and nortriptyline. Let's see about them one by one. Next slide. So varenicline is the commonest and most effective drug for tobacco addiction. So it's a partial agonist at the alpha 4 beta 2 nicotinic acetylcholine receptors. So that is the core of nicotine addiction. It reduces both craving and withdrawal, and it also blocks the reinforcing effects of nicotine. So when we think about the slide we discussed about, in ventral tegmental area, there is a dopaminergic neuron. So that is where all the addiction related neurobiology starts, right? So varenicline goes and blocks that receptor, and it has a partial agonist action also. So it prevents the massive dopamine release that happens after tobacco use, and thereby it uh, blocks the reinforcing effects of the nicotine. And it can be used as a monotherapy. And there was a trial that was conducted a few years back, which is called Eagles trial, and this emerged as a most effective agent compared to bupropion and NRT. These three interventions have been compared in that particular trial, and varenicline had quite impressive quit rates. Next slide. How do we dose it? So it comes in package like this. So you can see in the package there are two columns, the blue one and the green one. So this is called the starter pack. So starter pack, as you see, week one, week two. So week one, you see 0.5 mg, 1 tablet in the morning. 100. So from day 4 to day 7, you give zero point 0.5 mg, one in the morning and one at night, BD. From day 8 onwards, which is the second week, you give uh, 1 mg BD. So we'll discuss this in the coming slide. Next slide. Yeah. So we have to initiate the drug 1 week before the target quit date. For example, if my quit date is uh, today is 31st, right? So if my quit date is 7th of June, I have to start it from today, 1 week before the quit date. So initially, zero point 0.5 mg 100 for 3 days, zero point 0.5 mg 101 for 4 days, and 1 mg BD for next 1 week. And next, I have to continue the same 1 mg BD dose up to 11 weeks to 6 months. I can continue this. And later, when the person has improved significantly, you can start tapering down. So 1 mg OD you can like 0.5 mg BD you can make, then 0.5 mg OD after 2 weeks, and then after another 2 weeks you can stop it. So that's about Varenicline. So this is the starter pack. Similarly, there is a continuation pack also that is there, which will have 1 mg BD. Next slide. Side effects include nausea, insomnia, abnormal dreams, headaches, and many sleep-related disorders like sleepwalking, agitation, drowsiness, constipation. All these are commonly reported side effects. Rarely it can induce suicidality. So if the person already has high risk of suicide, then better to avoid this drug. And close monitoring is needed in patients who have severe psychiatric manifestations and suicidal ideation. Seizure disorder is also it's not a contraindication, but we have to exercise caution in seizure disorder because it can slightly reduce the seizure threshold, but not as much as bupropion. Next slide. So bupropion is another commonly used drug. It's an NDRI, norepinephrine dopamine reuptake inhibitor. So it is generally used as an antidepressant, but it can also be used in this because similar to nicotine, it produces a increased norepinephrine and dopamine levels in the synapse. So it reduces the withdrawal symptoms and attenuates the craving. Next. Dosing, initially you can dose it OD for 1 week, 100, then you can make it 110. Side effects include anorexia, decreased seizure threshold, weight loss, etc. And it can worsen the psychosis due to its dopaminergic action. So in people who have obesity, you can use it because it can promote weight loss. But in case of psychosis, schizophrenia, etc., and even bipolar disorder, better to avoid it. And it can also cause insomnia and dry mouth. These are the common side effects. Next. Nortriptyline. This is not a very popular medication in the recent days, but if you have a client who either who is not affordable for bupropion or varenicline. Varenicline is quite costlier. Bupropion is still affordable, but if the patient is asking for even more cost-effective options, then you can consider nortriptyline. So it's a second-line treatment, and it approximately doubles the chances of quitting compared to placebo. It is used off-label for um, when first-line therapies are not working. So it is started from 25 mg per day, and you can go up to 75 mg per day. 12 to 24 weeks, you can treat the patient with nortriptyline. It works by enhancing serotonin and norepinephrine levels. Side effects include dry mouth, urinary retention, and cognitive issues. So in older individuals, better to avoid. You can still give it a try in younger individuals. Next. So other drugs include cytisine. So cytisine is derived from a plant called cytisus. So this was used during World War II this plant was the product was smoked, similar to nicotine, that was found to be relaxing, and it was found to be enhancing the mood of soldiers. So that is how people got to know about this plant, and from there, when they derived the cytosine, it is found to act in a similar way to nicotine and varenicline. It acts directly on the nicotinic acetylcholine receptors. So it has a seven-fold higher affinity for nicotine receptors compared to nicotine. Half life about 4.8 hours. It is quite costly, and the availability is less. Nowadays, we can import this medicine from abroad, and in coming days, this will become routinely available in the practice. So this is another promising agent that is coming up. You have to dose 1.5 mg 3 to 6 times daily, and then taper over 40 days. So this need for multiple doses is one drawback of cytosine. So apart from these, we can there are off-label use of baclofen and naltrexone also for tobacco addiction. So these are less popular options. Next, tobacco vaccines were initially promoted as potential solution to nicotine addiction, but during the research stage itself, these were found to have significant adverse effects. So various things like Nicvax, NicQB, Qbeta, TA-Nic, all these things, they did not cross the phase 3 trials. So although it's an interesting idea, practically so far uh, they have not succeeded in bringing it in a safer way. But in future we may have tobacco vaccines against some mechanisms by manipulating the acetylcholine receptors. Next, so that completes the pharmacotherapy. uh, I'll give a brief about tobacco cessation counseling. Next, so tobacco cessation refers to, tobacco cessation counseling means in your short 10 to 15 minutes of OPD time that you have, you can talk about a few things with the patient to enhance their motivation and improve their quit rate. So it involves various steps that we'll see one by one in the coming slides. Next slide. So these are the 5 A's. So the counseling session will take roughly around 3 minutes if you do it effectively. So first step is ask. So asking is, if the patient comes to you for any other issue, for example, they may be coming to you with depression, anxiety, other things, or they may come visit you for some physical ailments. So you have to ask, have you ever smoked? How often do you smoke? When is the last time you smoked? And how many cigarettes you smoked in a particular day or a week or a month? Or why do you think it would be a great idea to quit? Have you been thinking about quitting? And do you also use a dip or a snus, which means do you use any smokeless tobacco also? So all these are points in ask. This is a rough scenario wherein a counselor asks about various aspects of tobacco use. Then next is advice. So as clinicians, we have a unique advantage that we can convey health information in a stronger manner. So when the general public talks about addiction, and when as health professionals, when we talk about it, it definitely creates some difference in the minds of our clients. So what you can say is that you can deliver a very strong message like the ones I've depicted here. Quitting is a single most important thing you can do to protect your health as well as your family. The effects of your second-hand smoke are harmful to your family. I suggest you to quit not only for them but for yourself. Then smokers who quit save an average of $120 a month. Something like this, a strong message we have to give to the clients. That is called advice. Next. Next, this is just an example for that. Next, next is assess. So assess whether they are willing to quit or not, and assess what resources do they have and what assistance do they need to consider quitting. So something like and also identifying 5 R's why this person has not been able to quit so far. So these 5 R's include relevance, risk, reward, roadblocks, and repetition. Next, so this is an example. Next, this is the most important part, which is to assist. So now that you're given the advice, you assessed various aspects. You also initially asked about their tobacco use pattern, etc. Now it is time for us to assist them. So this is where you say uh, specific things like it is best if you refrain from. In this example, I put drinking alcohol, but actually in our case, to quit smoking at the beginning of your effort to quit smoking, as alcohol is strongly associated with relapse. I suggest you ask others not to smoke in the house while you are trying to quit, as that may hinder your success. So you also tell your friends and other people not to invite you for the smoking, etc. So how you can assist them? Next, yeah, this is just an example. Next, next, yeah. Next is arranging. Arranging involves uh, scheduling a follow-up visit to review their progress towards quitting, preferably within the first week after setting the quit date. So as soon as they come, if they say like, "Yes, doctor, I want to try quitting," the moment they say this, you ask them to set a quit date. So that date could be, an immediate date, like in a few days' time or in a few weeks' time. But roughly around 2 to 4 weeks, you have to encourage them to set a quit date within 2 to 4 weeks, so that their motivation is increased. Like some people, they may set a quit date 1 year later or 6 months later. Then the motivation will again come down. You have to encourage them within 4 weeks frame, set one quit date, and then you will arrange the follow up, arrange the referrals, etc. Next. So teachable moments are various points of time wherein we can catch hold of these people and give our intervention towards uh, quitting the tobacco use. So these could be new patient visits, annual physical visit when they come up, annual routine checkups, even when they go for to visit for their children for the health checkup. We can encourage the parents or the grandparents who accompany them. Next, and women's wellness exams. This is less common in our country, but still in various urban places, many women also are indulged in tobacco use, and many women from rural areas, they're involved in smokeless tobacco use. So during other health checkups, we can integrate tobacco-related interventions also. Then problem-oriented office visits, follow-up visits after hospitalization. Many a times, people who smoke, they get hospitalized for COPD or myocardial infarction or some surgery. So during the follow-up, we can bring this conversation about treating their nicotine dependence and a recent health scare, which could be a recently they had a attended the emergency for some reason like high BP or chest pain, respiratory issues. So all those we can situations we can make use of these to encourage them to quit tobacco use. Next, so these are few more things. Due to want of time, I would like to just go through the slides, um, and because if you go in detail, it will take a significantly long time. So if you are doing an individual counseling for tobacco use disorder, the initially you have to go for an assessment phase where you assess all these various clinical aspects of tobacco use. Next. So once you assess it, you start building the motivation. So many a times these people are in contemplation stage. So contemplation stage means that 50% of their mind wants to reduce or quit. 50% of their mind wants to continue the tobacco use. So you will, so basically it is something like a balance, right? Something like a seesaw, wherein it is at a uh, horizontal level. You have to tip the balance, tip the seesaw towards the change. So you will use all these various skills like open-ended questions, affirmations, reflective listening, and summary. This is called summarize this O's. So you do not take a stance of an expert here. In motivational counseling, you take the stance of a companion. You will say, okay, from now, where do you think we can go? What are the aspects of smoking do you think you can control from now on? What are the various changes you are going to bring to your lifestyle? So like that you ask open-ended questions. You also make some affirmations. When the person says that if I decide, I can actually completely go out of like I can completely quit smoking. You reinforce that by saying, yeah, even few years back you said you were not smoking for 6 months. That's a great thing. So that means that you will be able to quit once again, something like that. So like that, some affirmations, reflective listening, and finally summarizing whatever you have discussed. So all these things will build the motivation. Next. So again, this we have discussed, right? We will fix a quit date. We will discuss coping strategies. We will discuss what are the pharmacological options available. So all these things we will discuss with the client. Next. Then behavior skills training, which includes avoiding the high risk situations, like avoiding whatever that can trigger their tobacco use. Then using some substitutes like sugar free chewing gums instead of smoking or chewable tobacco, sipping water whenever they feel the craving, and using relaxation and mindfulness techniques. Next. Then once they are better, once they reduced it or once they stop it, you do not stop your sessions. You continue to see them every month. If they completely quit, see them once in 2 months or 3 months. So in each visit, you reinforce the progress. You appreciate them if they are able to be successfully control their nicotine use, etc. And even if they lapse, like they were not smoking for 6 months, then they had a smoke. So you normalize it. You normalize the lapses and relapses. And if people are coming with relapses, you manage the relapses. So this is called lapse management and relapse prevention. Next. Yeah. So this is how our response should be based on whichever stage the person comes in. In pre-contemplation, the person will say, "No, I'm not going to quit." In contemplation, they'll say, "Maybe I can quit." This is the stage where most of the clients come to our clinic. Preparation, they already have a plan for quitting. Then action, they are actually able to do it. They are able to stay off tobacco. And maintenance, they are able to keep the change behavior going. So this is about the different stages of change by Prochaska and D. Clements. Next. Excuse me. Yeah, these are all self-explanatory. Next. Next. But this we already talked about the FTND. You can also ask about something called motivational ruler or readiness ruler. So how motivated are you to quit tobacco and how ready are you to quit tobacco? Give a number to it. Next. This is called the motivation ruler. You can, along with many other things that you note down in your notes, you can also say motivational ruler. If 1 is the lowest motivation, 10 is the highest motivation, how much are you motivated to quit? So you can write a number. If patient says 4, for example, to improve it further, you will ask them, why do you say it is 4? Why not 1? So then they will say, no, 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 I have plans of quitting. I also want to quit also, but I was not able to do it. That's why I'm giving 4, something like that. So that in that way you can reinforce that uh, they can go into higher and higher motivational stages. Next. Yeah. We'll also run through this. Next. So this is a 5-day plan to get ready to quit. Not quitting itself, but getting ready to quit. So date 5, you will say what are the reasons to quit. You write it down. Tell the family and friends that you are going to quit, and stop buying tobacco. This is what happens on day number 5. Day number 4, pay attention to why and when you are feeling the need to use tobacco. Find some new ways to relax. Find some new ways to holding something in your mouth instead of tobacco. And in hand, for example, in hand people can hold something like a lollipop or something, which can give them the feel of having something, right? And in the mouth for chewing tobacco, you can use something like you know uh, something like sonf, or something like chewing gum or toffee, whatever it is. So to just to give the feel of that, and think habits or routines that you may need to change. For example, some people may choose to go to gym regularly, or attend yoga sessions, etc. So think of all those things that you can do. Next. Day 3, make use of the things that you could do with the extra money you save. For example, one pack of cigarette is costing roughly around 200 nowadays. So what else you can buy with the same money? And think when to reach when you need help. You can reach out to the psychiatrist, you can reach out to the doctors, like that. So think when to reach. Then day 2, clean your clothes to get rid of the smell of smoke. As I already mentioned, many a times uh, there should not be anything that reminds them of their smoking, right? So clean your clothes. Day 1, what you will do is think of the reward that you will get after you quit. For example, if I quit smoking for 1 month, I am going to buy myself a new headphones or a new clothes. So keep some reward like that. Then get your teeth cleaned. Visit a dentist. Many a times, people who smoke and people who use chewable tobacco, they have a lot of nicotine stains on their teeth. So go and get it cleaned. Throw away all your tobacco products that you have in your home, in your workplace, in your car, etc. And put away the lighters and ashtrays. So I mentioned in one of the slides that conditioning plays a major role. So getting rid of all the things that remind them of their smoke is very essential. Okay, so this is a 5-day plan that you can suggest them if they are not ready. So in these 5 days, they can actually get ready to quit smoking or tobacco use. Next. Then the actual quit day comes, and from then on, it will become quit day plus 1 plus 2 plus 3 plus 4 plus 5, something like that. Next. So this we've already seen about it, 5 hours. Next. Next. And these are some basic principles of managing the craving. One is delaying. So if any urge comes, you delay it by 5 minutes. So in that 5 minutes, generally it will come down. Then deep breathing, drink water, do something else to distract yourself, like exercise, etc. Next. So these are the very various coping strategies for irritability: walk, hot bath, relaxation; fatigue, taking nap or exercising; insomnia, avoiding caffeine intake; dizziness, change the positions slowly; hunger, have some low calorie snacks; craving for cigarette, you wait on the urge, distract yourself, drink water, read, exercise, etc. Headache, hydrate yourself adequately, and eat a small snack. So these are all small alternatives you can suggest when people are undergoing the withdrawal symptoms. Next. Sometimes we may need to involve the family. Generally, it will be adequate if we address the patient alone. In some cases, we can use the family. family psychoeducation, communication skills training, behavioral contract, and family support. These are the various aspects of family interventions. Next. So, first, educate the family members about the health consequences, withdrawal symptoms, how to support the patient without criticizing in a non judgmental way. Next. This is just an example. Next. Communication skills training, how the family has to communicate with them through active listening, assertiveness but non-confrontational, and how to talk about triggers and slips calmly. Next. This is a behavioral contract wherein the person has can discuss with the family member for about you know various for example, in this case they are using uh, let's make a family contract. What is the realistic first goal? To avoid smoking for 1 week. So excellent. What would be the good reward? The wife says we will use the money saved for having a dinner outside. So this is a very short-term goal, which is 1 week of quitting, which is many patients may agree. And once they are able to use that money for something else like a dinner, then they that will reinforce them. So this is how we can involve the family. Next. Next. So also the family can also play an important role in bringing these people early to the doctor if they are having a lapse. So they recognize the early relapse signs, they avoid the blame, and they reinforce the coping strategies and stress reduction. Next. Yeah, these are the other psychosocial interventions like CBT, motivation interviewing, and stress management and relaxation exercises. So with this, we can consider this session complete. So just to summarize the session, so initially we discussed about how nicotine as a chemical is addictive through the nicotinic acetylcholine receptors and various brain areas like the reward pathway, basal ganglia, extended amygdala, prefrontal cortex, how these areas are involved in nicotine addiction, and how connection with various connection of the nicotinic neuron with other neurotransmitter systems like serotonin, norepinephrine, dopamine, how this plays an important role. Then we moved on to discuss about the Fagerstorm tests for nicotine dependence, uh, carbon monoxide testing. Then we discussed about the criteria for dependence, ICD-11, DSM-5-TR to make a diagnosis. Then we discussed about various pharmacological uh, options for addiction like nicotine replacement therapy, other drugs. Then we discussed briefly about tobacco cessation counseling and brief interventions. So that completes my session on understanding and managing tobacco addiction. Thank you.
Thank you, Dr. Shyam. That was quite in-depth session on the tobacco cessation, and we got to know much in detail about what can be done in the need of our. So I will just, yeah, I'll just share my screen to quickly take through what can be done in the form of a non-invasive brain stimulation methods. Okay. I think my slides are visible. So I will just take everyone quickly. And what I want to put it is from the compulsion to control and the use of non-invasive brain stimulation such as the TMS, TDCS, VNS for nicotine use disorder. To just quickly pick up the point that why it is really important, what an IBS is going to solve. Taking from the survey, it is 1.3 billion people use tobacco worldwide, which is more than one in every eight individual. 25% people achieve the substance, like, abstinence with best pharmacotherapy and the NRT, what we just heard about in detail, nicotine replacement therapy combined. And there are 70% of the smokers want to quit but fail repeatedly, driven by the craving circuitry. Now, there are drugs, of course. So, like, what we have just seen in detail, that there are the CNS side effects, residual craving, and long-term adherence is poor. Not everyone stick to the drug regimen. Nicotine replacement therapy does its job well, but does not rewire the craving circuitry or restore the prefrontal inhibition. Psychotherapy, CBT, yes, it needs a neurobiological adjunct to sustain craving suppression. And what we are talking about in the brain is the dorsolateral prefrontal cortex, which is involved, bilateral insula, anterior cingulate gyrus, and there are other targets, what we will be looking at it. So one of the first things which come into the mind is like what is the TMS? So the TMS stands for the transcranial magnetic stimulation, which is an established non-invasive way, non-convulsive. There is no seizure. And it has been FDA approved for depression, OCD, and chronic pain. And so as the smoking cessation, it can be used in other effective neuropsychiatric conditions like stroke rehab and others. But we just limited our today's discussion for the smoking cessation. So what is the RTMS and mechanism and the neural targets? High frequency, which is the 10 hertz, 10 taps per second. So it is a high frequency given to our left prefrontal cortex. It induces the cortical excitation and hence the top-down inhibitory control over our limbic chroning circuit. So while we are stimulating our brain, we are inhibiting our limbic circuit, which is involved in the addiction. Now, the TMS biologically reduces the resting state of the insula. Now, we know that the insula is fired in most of the studies in addiction, and it decreases the DLPFC, which is the dorsolateral prefrontal cortex connectivity. So, blunting the reward salience of the tobacco cues. So, just as we saw that if there is a person passing by a tobacco shop or the friends are smoking while inhibiting the DLPFC, we will not drawn toward that cues. So I think that is one of the things what biologically we can able to do. It reshapes our frontostriatal pathways, restore balances between the executive control networks, what is known as the ECN, and the default mode craving networks. So we are talking about targeting the ECN and DMM, which is very highly talked about in addiction disorders and other mood disorders recently. Higher frequency DL stimulation also improves the striatal dopamine release. Everyone who have wanted to quit and searching online, be it on Instagram, TikTok, well, the TikTok is banned
Hello.
in India, but
Am I audible?
uh, yeah, you are audible.
Yeah, sir. Actually, your slide is too small. We cannot. I cannot
Oh,
make out what's written in it,
okay. Yeah.
and your volume is also very low.
Oh, okay.
Yeah. Thank you.
So, when we are talking about the high frequency stimulation induces the striatal dopamine networks in the medial prefrontal cortex. So, we are focusing on the how we are with the use of the TMS can able to change the circuitry. Now, there are several trials which also suggest that there is an intent to treat. Quit rates is 17.1 in the TMS trials, which use the BrainsWay deep TMS trial like a H4, whereas the 7.9 in just the sham. There are complete quit rate in what we are talking about the 3 to 4 weeks. There are 30% of the people do achieve the complete quit rate, and it is based on the eight randomized controlled trials, which is quite significant. And of course, when these trials been done and you do with the psychotherapy, you talk about the holistic care approaches and the TMS adjunct with the pharmacotherapy, I think that is the best way forward. Moving on to the next non-invasive brain stimulation methods like TDCS, which is a transcranial direct current stimulation. So it also uses very weak electrical currents to modulate the brain activity in the specific areas, which just range from 1 to 2 milliamps of electric stimulus. TDCS again is been painless, non-invasive, and well tolerable across the lifespan. And what we are looking for is the mechanism targets and the polarity logic. So the anodal, which is the positive TDCS over the left DLPFC, is a sub-threshold membrane depolarization. So it doesn't like TMS penetrates deeper, enhances the our evoke potential. In the TDCS, that's not the case. We are talking about increasing cortical excitability and enhanced top-down craving control. So there is a cathodal, which is the negative side, have to be placed on the F4. So essentially, we are stimulating our bilateral prefrontal cortex, cathodal on the right side, and anodal, which is the positive, on the left. Now, the cathodal brings the hyperpolarization, and the right hemisphere craving hyperactivity. Bilaterally, we can able to show the synergistic craving reduction. Now, effect is cumulative across the session, so it's not just that one sessions can able to provide you the the benefit effect, but over the period of time you can see the differences. Now, if we just look the same, so there are protocols. As I say, the intensity is about 1 to 2 milliamps. Session duration lasts for 20 minutes. The total sessions can be done 5 to 10 over like 5 daily sessions, 5 days per week, for 3 to 5 weeks. Anodal is on F3, cathode on the F4, and it's 1 month with the maintenance sessions, we can able to see that there are quite a sustainable results what we are looking for. And again, based on the literature reviews, there are recent reviews which also shows that TDCS yields moderate craving reduction across addiction disorders, and the effect size does matter. So, and if we look for the gold standard in this TM like trials, it should last for at least 5 to 6 weeks, where we can able to deliver from 20 to 30 sessions to get a very positive impact. Now, the emerging evidence is from coming from the another modality called the TAVNS, which is a transcutaneous auricular vagus nerve stimulation. Now, TDCS, or unlike the TDCS, which directly acts on the brain, the TAVNS, we are stimulating the vagus nerve. Now, vagus nerve is like body's superhighway connecting from our brain to body, and roughly 80% of the signal from the body to the brain passes via this vagus nerve. Now, as you see in the image, that the vagus nerve, we can able to tap the auricular branch of the vagus nerve from the ear. A clip is being placed and we can able to stimulate it. And there are very emerging promising evidence coming out from the TBNS in smoking and addiction disorders. And why is it so? Now, if you look at the two of the vagus nerve targets over here, there is it only goes from the two of these networks. What you it's been put up in the purple color called the raphe nuclei and the locus coeruleus, and then it is from there it is regulating the norepinephrine and serotonin pathways, and there it goes all around from our insula, which is already we know that it's been implicated in addiction disorders. We are talking about our anterior cingulate pathways, about basic upon the mood disorders. And what it really does is it receives the insula, which receives the rich signal from the nucleus tractus solitarius or the vagal projections. It have a privileged circuit access. Right now, if we look for any brain-based stimulation, they have to be placed over like our prefrontal cortex, and then it should go inside. If you look with the VNS, we can able to go from the bottom up approach. The withdrawal management is much better used for the TAVNS. Some of the devices, if when you are comfortable, can be done at home. Like, the TMS can't go home, but the VNS, there are possibilities that it can be delivered. Primarily, I will, like, in the withdrawal stage, I always recommend the people using at the clinic, because there are other comorbid conditions what we have to look for. But I think it is much simpler, and there is a combination potential. For example, when you are on a pharmacotherapy like NRT or penicillin primary, from the neuroplasticity window, we are able to do the pharmacotherapy behavior change. So again, how does the, the TAVN is the mechanism in the neurocircuit? Electrodes are placed in the auricular branch in the left ear, because like the right ear directly, the right side connects to the aortic branch of the heart. So we don't want to stimulate the right side. So it is on the left side. Afferent signal going into the nucleus tractus solitarius, which is just like, I will say, junction, where the, it's just like a train junction, where the vagus nerve releases the signals, activates it, and then norepinephrine released through the cortex. Similarly, the same projections also lead the activation and suppressing the cue-induced craving and withdrawal at the amygdala, the insula, and the arousal. Now, there are other factors like the TIVNS promotes the BDNF release, which is the brain-derived neurotropic factor, enhances the parieto-temporal connectivity. So it restores the anti-inflammatory tone, and it's also reducing the withdrawal inflammation. When we are talking for the VNS in some of the studies, including the alcohol substance use disorder, there are good evidence which are coming, and then there is a TVNS. It's so exciting that if we just look, what is the year on year growth in TAVNS, it is roughly 33%. So I think it is making progress, but we have to just wait for longer time to go mainstream. But I will say that the TAVNS in maintenance or in acute withdrawal stages make more sense. So now if I just look the comparative overview, like where we should use TMS, TDCS, and VNS, I think there is for TMS, there is a very good level 1 data, FDA cleared. For TDCS, yes, there is a grade B data for addictions, and there is a TAVNS for substance use disorder. Where we should be looking at it. Now, the TMS is the first choice for motivated, treatment resistant smokers, strongest abstinence evidence, and we are looking for a dedicated NIBS program. TDCS is best for craving suppression, adjunct to the NRT and the pharmacotherapy. Portable options, home maintenance programs can be looked at, and the TAVNS is ideal at the withdrawal management. So, sometime when we're looking for the hospital admission, I think at that time in the withdrawal stage, especially with the alcohol use, not with much of the smokers, smoking, or like as Dr. Sham was telling, in the first week or the first 2 to 3 weeks, if we just look the TAVNS as the withdrawal management, I think it is best suited for that. So every brain stimulation methods have its own advantages. We are looking to choose the best one. And then there is a clinical integration framework. So it doesn't just say you go to our, for example, if we take our example that you come to a Buddhi clinic and then you just look the TMS. No, there is an assessment stage where you have to be assessed in depth that what really is required. Second, we go for the stage one, which is week 1 to 3, where we are looking for the deep TMS or a high frequency TMS can be done along with the pharmacotherapy. And the psychotherapeutic approaches stage 2, week 3 to 6, where we are looking for weekly TMS booster sessions, like say 1 or 2 per week, looking at the TDCS home sessions if it is there, and the motivational interviewing and the cognitive behavior therapies. And thereafter, we are looking for a relapse prevention program, like the TAVNS can be done. Again, the psychotherapy can be continued, and every 4 weeks the outcome is being monitored. So this is one of the clinical integration framework what we are looking for all the people coming with any substance use disorder. And one of the, the key points here, that it is done in one place in an interdisciplinary team which communicate with each other. So the team which have done the assessment and the team which is following the outcomes are talking about the care results. We are working in sync to provide the best possible outcomes. So it is that approach what makes the difference. So if I look at the conclusion part, it is integrating the non-invasive brain stimulation methods proved to be vital in smoking cessation. An effective management program include a 360-degree care from assessments to pharmacotherapy, psychotherapy, non-invasive brain stimulation methods, and holistic care, which do include the principles of Ayurveda and naturopathy for calming and non-stigma associated treatment protocols. Seeking professional help is the first step toward recovery. And if any of you needs more information, you can visit to our website, or you can look at the number on the screen. And for any other questions, just feel free to just email us at care@buddhiclinic.com. So thank you. I think we have some questions. Okay. So I think there is some questions which is for Dr. Sham, that what is the amount of tobacco and nicotine delivered to the bloodstream after someone takes smokeless tobacco like gutka or katha? Any, and what treatment regimes to follow if on the Nicotax if someone takes smokeless tobacco, as is often in the case in our country. On the world no tobacco day, we will take a pledge that we should not smoke and make the world smoke free place. Thank you.